question that comes up all the time is a BTK inhibitor plus or minus a monoclonal antibody. And I think we've seen mixed data that in some of the studies, adding rituximab to ibrutinib didn't really look like it enhanced anything to ibrutinib monotherapy. And then, of course, we've had data looking at acalabrutinib and obinutuzumab, and that looked like there may be more enhancement in that. Of course, no head-to-head data, but certainly I think one option is that many of us will use BTK monotherapy. However, I do think that there might be some subtle times where where using a CD20 monoclonal antibody could have advantages. If somebody's got autoimmune cytopenias that are really prevalent initially upon starting therapy, and you want to sort of calm that process down and then add in the BTK. I think there are different ways where monoclonal antibodies are still very useful on our patients, but I think the data, again, we don't have conclusive data that adding a CD20 monoclonal antibody necessarily to a BTK inhibitor has changed, has improved survival or PFS, greater than just a BTK inhibitor alone. So I think that's something to consider. When also talking about comorbidities of our patients, and we were talking about cardiac issues with our BTK inhibitors, obviously the second generation BTK inhibitors, such as acalabrutinib, and of course now zanubrutinib is being studied, and there are more, that certainly, when you're thinking about anticoagulation, antiplatelet agents, cardiac risk factors, obviously there is head-to-head data that is still pending. So meaning these studies are enrolled. Actually, one is closed to accrual. That's the ibrutinib versus acalabrutinib in high-risk relapse patients with CLL. And so knowing if the second generation BTK inhibitors have decreased frequency of adverse events such as the cardiac issues, bleeding issues, hypertension, I think, the head-to-head data is still pending. Obviously, we have lots of the data on acalabrutinib, not head-to-head, but on acalabrutinib suggesting that the adverse events may be less than ibrutinib. But I think the head-to-head data is really what we're all looking for to really see if there's decreased frequency. But certainly, if you're considering a BTK inhibitor on your patient and you're worried about some of these issues, many folks are prescribing the second generation BTK inhibitors over ibrutinib. Again, I'm sort of waiting the head-to-head data to see. And so those discussions, because now you have more than one BTK inhibitor that you can choose for your patient. So certainly that needs to be in discussion too. And then of course, when we're talking about the venetoclax obinutuzumab combinations, it's sort of risk stratifying your patient to see if they have low, moderate, or high risk for tumor lysis, and then taking strategic measures, obviously, to mitigate for tumor lysis syndrome. And certainly if you have an older patient, maybe some borderline renal insufficiency, and maybe moderate or high risk, you might require, then certainly hospitalization is something to obviously consider, because you really want to monitor for tumor lysis and protect those individuals because it's very treatable. Those individuals are going to require treatments to monitor for uric acid and electrolyte abnormalities more frequently than patients who are not getting a venetoclax-based combination. And so certainly you got to take that into consideration. But certainly the advantage of that is certainly there's a time-limited duration of therapy for using venetoclax obinutuzumab. So certainly those discussions need to be held with your patients, and the comorbidities need to be taken into consideration. Now, in terms of chemoimmunotherapy in the frontline setting for patients, certainly I think we still discuss the data that has come out from MD Anderson and others looking at that long-term tail of patients with a 13q deletion who are mutated, favorable disease characteristics, who may be in remission long-term after chemoimmunotherapy with fludarabine, cyclophosphamide, and rituximab. And so certainly I think that's still a discussion in that patient population. Many patients have obviously clearly moved away from outright chemoimmunotherapy, given the side effect profile that we've seen with chemoimmunotherapy. But I think it's still a discussion in that unique subgroup of patients who have favorable disease. And so I don't necessarily throw that entirely out of the water, but clearly most of my patients don't choose to receive chemoimmunotherapy very frequently anymore, given all these new agents that we have. And so we see much less use of chemoimmunotherapy in our CLL patient population. With regards to our high-risk patients, as discussed previously, like the 17p, p53 complex karyotype, they're unmutated. Although unmutated, I think we wouldn't. They're higher risk than the mutated, but I think your choices are a little bit more broader. When we talk about the 17p or p53 patients, the longest data we have is with BTK inhibitors. So I tend to, if upfront untreated patients, I still favor a BTK, but there's very good data for venetoclax. The question that I think many of us are still grappling with is because the venetoclax-based combinations are time-limited duration in those high-risk patients, such as a 17p or p53, such as venetoclax obinutuzumab, the duration of therapy is 12 months. So are we comfortable stopping the patient with a 17p or p53? Are we comfortable stopping at 12 months for those patients? And I think that's where we're still looking for longer follow-up and longer data. And so I still preferentially will put my 17p p53 patients on a BTK inhibitor up front and continue for monotherapy. But it doesn't mean that the venetoclax obinutuzumab combination wouldn't be adequate, because we obviously have very good data that that drug works very well in these high-risk patients. But the stopping versus continuation of venetoclax, for example, continuation of the ven therapy is something that we don't have enough follow-up on those high-risk individuals. So certainly you just have to, are you comfortable taking those patients off after their end of their time-limited duration, whether that's in Frontline, or if you're doing this with rituximab in relapse via the Murano study, are you stopping at 2 years of therapy? And so I tend to keep my patient on chronic therapy if they're high risk in that sense. But I think the data is still, pending.